Go ahead, sir.
So, can I start, sir?
Sir, please.
So, first of all, apologies for the slight delay. I just got held up in hospital, and it's good to be back. It's good to be back in a hopefully a much safer environment. Today's talk is about actually a repeat talk. It's about external fixation and its utility in orthopedics. The talk is scheduled in this pattern. We will be talking about a few initial history about the external fixators, the indications, advantages, disadvantages, types, components, the mechanics and the biology behind it, and the complications that can occur while doing an external fixator. So that brings us to the first question. What is an external fixator? And it's a very simple English definition, which says that the external fixator is a device which is placed outside the skin while the bone is stabilized through wires and pins, which is then connected to an external frame. So the photograph on the left side of the screen shows you pins which are driven into the bone and which are connected to an external frame. So this essentially constitutes a external fixator. So if you go to the history, I'm sure you will read a lot about the Danish physician who is Lambert. Lambert is his name is the one that comes out when you read the history of the external fixator, simply because Lambert took what was Parkel's external fixator and made it a little more scientific. If you can see carefully on the diagram on your right, you will see that they are spacing guides which allowed you to drill at particular fixed lengths, adjustable lengths actually. There is a trephine which can allow the pin to be driven, and you can see the construction of the clamp, which is quite similar to the one that we see in the present day external fixator also. So essentially it is Lambert that is credited with creating the prototype of the present day fixator. Many names are also involved with the external fixator development, namely Anderson, Stader, and Hoffman. All of these people have a fixator named after them. And you have to remember that the history of the external fixator actually parallels the history of war among humans. And because that is where you get the maximum number of open injuries. And most of the developments in the external fixator took place during wartime. The concept of transfixation pins, the concept that you could distract bone using a fixator. You could also compress, do the opposite, do the compression using a fixator. And the major addition that after the World War is essentially contributed by a Russian surgeon who is very popular here, known by the name of Elizarov, who developed the ring frames, and a marriage between the old frames and the ring frames gave rise to the hybrid fixators, where the good things about both fixators were combined. So now coming to the indication, when do we have to use an external fixator? The birth of the external fixator took place due to trauma. And the indications still are essentially trauma, but as time has progressed, it has been extrapolated to non-traumatic indications. So the first indication is temporary fracture care. So this one concept is that you would be familiar with is damage control, so that the patient has multiple fractures, plus he is critically ill. He has other system injuries, and his critical illness preludes you from doing a major multiple fixation of all fractures. So use a simple and a quick technique of external fixation by which you can quickly stabilize all the bony injuries. The external fixator is also used to resuscitate the soft tissue when the bone is fractured. So that is a temporization. So you have a fracture. Let's assume that somebody has an injury, a severe head injury, which has to be dealt first. and there is a significant delay in the fixation of the fracture due to some reasons. So you use an external fixator to buy time and stabilize the fracture, and that's called temporization. In some fractures, like the pelvic ring injuries, it can be used as an emergency device. It can actually be used to control hemorrhage. In periarticular fractures, it actually brings the fractures into reasonably good position. It also gives rest to the soft tissue, permitting healing. Now, it is not that external fixators can be used only for temporary fracture care. They form an option. They're a good option in open fractures, or in other fractures also. Typically, the largest indication for an external fixator is open fractures. So if somebody really asks you what is the purpose of a fixator in open fracture, the answer that should promptly come out is for soft tissue management, bony stabilization and soft tissue management. External fixators, especially the hybrid varieties, are common forms of treatment in periarticular fractures, especially the tibial plafond, the tibial plateau, where they are very popular. It can also be used in pediatric fractures where you don't do extensive internal fixation and you can stabilize the fracture for a short time using an external fixator. The external fixator also has an indication in correction of malunions, treating non-unions, fusion of joints, arthrodesis, cavity management and bony stabilization in osteomyelitis, and also correcting limb length deformities and link equalities. So this is just one of the indications. So you can see a bony injury, you can see a hemorrhagic bullae. Hemorrhagic bullae is an indicator of severe soft tissue trauma. And this is probably not the right time to take a knife, open up the fracture and go down to the bone. Here, the external fixator will maintain length, give pain-free mobilization to the patient, and also allow recovery of soft tissue. In an open fracture, the external fixator is a device of choice, which allows you good, appropriate soft tissue management. The concept of damage control orthopedics. When you have injury that involves more than one body system, including orthopedic injuries, the patient is so sick that this is the concept of what we call the second hit syndrome. The patient already has got a trauma, and if you rush him to the theater and operate him again, you're inducing, somebody has already said, isn't it, that surgery is but consented trauma on the patient, consented assault on the patient. So that raises another sequence of multi-organ dysfunction, and which can end up in even death. So in this case, we use the external fixator as a temporizing device, a quick deployed control of all bony injuries, allowing the major injuries to be treated on priority. Infection, we also talked about how it can be used for gap management after debridement and stabilization. Corrective surgery, limb lengthening, the Lizarro fixator is a prime example, and the external fixator is a versatile tool that helps you to do limb lengthening. It can also be used in definitive care. Now, this is an example of a child who's got a large abrasion over the foot and ankle. What would have probably been treated by close reduction and casting, because of the wound has to be, you have to tend to the wound. A short external fixator as well as soft tissue management of the abrasion has been done. And all you need to hold this is for 2 to 3 weeks and the fracture unites. So here the external fixator is functioning like a definitive fracture care device. This is another example we spoke about, the tibial plafond, the tibial plateau. The fixator can be used especially in the presence of extensive soft tissue injury to get definitive treatment. The point that you have to remember here is the fixator functions on the principle of relative stability. It is not absolute, though it appears very rigid. Since it is far away from the bone, it gives relative stability and promotes healing by callus. Fusion of a joint. The Charnley's clamp, I'm not sure whether the younger generation has seen a Charnley's clamp, is a prime example of an external fixator, which can be used very, very suitable to fuse a joint, especially the knee and ankle. Treatment of non-union by correction of deformities, cycles of compression and distraction can be given through a fixator, or you could bone graft while reducing it. which can result in healing of the non-union. Deformity correction, very popular, the just fixators, the Ilizaros, which can be used to correct the foot deformities, different kind of deformities. So all these are indications for an external fixator. The external fixator comes with a lot of advantages. It is minimally invasive. It protects the local biology. If the soft tissue is injured, there is minimal interference with the soft tissue cover. Not only that, unlike an internal fixation where we are opening up the bone, stripping the periosteum, the iatrogenic damage that you cause when you treat the patient is minimal in an external fixator. It can be applied rapidly. By easy, we mean that it has a low learning curve and it can be deployed in multiple situations. It allows soft tissue management. It is probably the device of choice for open fractures. If you have a little maladjustment with the fixator, it doesn't take much. You can just take the patient back, and in fact, sometimes even without anesthesia, you can just gently reduce the fracture, realign the fixator so that you get adequate reduction. In the presence, remember that the dose of metal that the patient gets with internal fixation is very high. Whereas in the external fixation device, they're just pinheads which are into the bone. The rest of the construct is outside the patient. So there's very little foreign body. It is very versatile. You can correct bone deformities. You can be the cause for lengthening. And some people, I clearly remember we had an actor who had a clavicle fracture and we said, a badly one, and we said we'll plate it. He was very insistent that he wanted a good scar. And probably that was the only time I've used an external fixator for a clavicle, and we got really good union. And there were just 3 or 4 skin marks what was there. Sometimes the external fixator is not a panacea for all clinical situations. If you don't have experience, especially with the ring fixators, you must be very clear of the safe zones wherein you are endangering the nerves and vessels. You must be careful. Obviously, it is very highly equipment dependable. It's very uncomfortable for the patient. A lot of patients complain about the weight as well as the challenging movement in the ward or rehabilitation. So these are some problems that you face with an external fixator. If you expand on the problems, you can divide them into mechanical and biological. Now, distraction of the fracture site is actually an older problem. It has now really come down. It usually used to occur because the clamps would not remain tight on the rod for a long time, and you would get some play, and you will have some loss of reduction or a distraction of the fracture site with movement. Inadequate immobilization is sometimes because there is a high propensity for external fixator pins to be infected, and sometimes you might have to remove before you do. So you would have a fracture which is immobilized by an external fixator. You find pin tract infection. You are forced to remove it 3 weeks later, which is not enough for the fracture to consolidate. The device is also famous for pin-bone interface failure because the pins may break at the junction of the bone and the pin. It adds to the weight. Like we have said, it's very uncomfortable. A refracture. Now, this is the reason why, because we always tend to keep internal fixation equipment for a longer period. We usually typically plan and we say we will remove a plate after 1 year or 1.5 years. Whereas a fixator cannot be kept that long. It is very difficult to keep a fixator on for more than 9 months or 12 months. It's extremely uncomfortable, and then you get major problems. So what happens is you tend to remove fixator early, and especially in children, where sometimes you use the fixator as a definitive device. The fracture has not moved through its stages of consolidation and remodeling. You have removed it early, and that brings a risk of refracture. The other biological ones are fairly common. Anybody who has been in the orthopedic ward has seen pin tract infection. Neurovascular injury is not uncommon. Sometimes you have to pass through muscles and tendons and you start limiting movements of the joint, and you can cause soft tissue contractures. Now, depending on what are the different types of fixators, if you go by construct, there are 2 types. One is the pin rod, that is a Schanz pin and a rod, a hollow rod. And the second is called a wire and frame. So you have thin wires that go into bone, which need to be tensioned, and they are anchored to a frame. you can combine the two into a hybrid fixator. Geometry is actually the spatial arrangement of the fixator around the patient. So sometimes you put it only on one side of the bone. Here it is called monolateral fixator. Sometimes the same pins will be having rods on both sides. You would call it a bilateral fixator. It could be an arch that connects the pins. It could be a semicircle, or it could be a circular. Again, here you can combine many things together and call it a hybrid fixator. So this is just an example of the geometry. Monolateral, I'm sure you heard the name of Hoffman or the AO fixator. That is, a pin is only on one side. Bilateral, the Hoffman fixture. Rolf Hoffman described it during the World War. It's a very common fixator. It goes right through the bone. Sectoral, the arch, which is not really very popular. The arch fixator is the AO type of fixator. Semicircular, the Hoffman middle, the circular, of which Elizaro is the major prototype. And you can combine. You can add 1 and 3, 1 and 5 and make a hybrid fixator. So these are the geometries. These are the structures you can create using a fixator device. So there are some other terms that are used to describe fixators. A modular fixator system is where you put one rod into one part of the bone, which is fractured, another rod on the other part of the bone, which is fractured. Then using these two and a loose rod, which is interconnecting, which is marked in red here, you reduce the fracture and then tighten the nuts. This is called the modular. Very, very popular in the distal radius, where you have a clamp which connects the metacarpal and the forearm pins. Monotube, this is commonly called as the railroad. LRS is a example which contains a expandable piston within the fixator, which allows bone lengthening. Elizaro, very popular, probably the topic of a discussion later by some other faculty, which is because it contains so much of principles that it is almost out of scope of an external fixator alone kind of presentation. So that's the ring fixator. Combination, what we call hybrid, a ring and shank pins and using multiple rods. This is common because it reduces weight. It also actually adds fixation. The shank pins is a very strong device that holds on to bone. So they're very common in periarticular fractures and can be used in secondary procedures. Hexapod, again, a common system where there are 6 axes of movement between hinges which can move. This can be actually moved by a computer and a motor. Now you have what is called an 8-axis hexapod. It is still called a hexapod, but it has 8 axes where even more complex deformity correction can be done. The hexapod. This is from the AO. I must confess, I haven't seen this. This is the pinless fixator, which actually holds, the closest that comes to this is a Crutchfield tongs, which you use for cervical traction, where actually you just from externally just keep tightening so that it just punctures the skin and bites the bone and gets anchored. So you don't drill into the bone, you don't enter the medullary cavity. It's a quickly deployable pinless external fixator. Now coming to the structure, the components of the fixator. The bone is connected to the pin. The pins are locked onto by the clamp, and they are connecting rods that connect the clamps. It's a very simple device containing these 3 components. Now the pin is the most critical element of this frame because it is the connection between the biological and the physical tissue. So the critical thing that has to be remembered here is the pin diameter. The pin must be large enough. The larger the pin, the more stiffer, the more stronger it is. So the equation is that the bending stiffness is proportional to the 4th power of the radius, which means the stiffness is 4 times the radius, r raised to the power 4 as you get increased. So using that corollary, a 5 millimeter pin is 144% stiffer than a 4. Just a difference of 1 millimeter has made this difference. 2 things to remember. You could put too big a pin and cause a bone fracture, which must be avoided. Putting the pin onto the bone itself is an art. You have to respect the soft tissue. You have to respect the bone and apply the pin in such a way that it is seated correctly. Only then does the full qualities of the pin are utilized for fixation. So these are the examples. If you watch the picture on your right, you can relate it to the written description on the left. So the first one that is seen is a 2.5 mm shank pin, sometimes used in the forearm. A 4 mm short thread pin. This is a short thread pin. Remember that the weakest position of the threaded part is the weak part of the shank pin. Remember that the core becomes thinner. So the core, the diameter of the shaft behind the thread is actually thick. It will not break. The diameter of the threaded part is very thin. The core diameter is thin. And the junction between the thin and the thick part is where maximum stresses come. And typically the pin will break there. So ideally, when you put the pin into somebody, the threaded part should be fully anchored into bone. And the shaft of the shank pin only must be seen. So for example, if you take the third pin, which is actually the 5 mm pre-drill, you can see the flutes on top, which allows you to pre-drill. You don't have to use a drill here. So what it does here is, suppose you put so much of thread outside, you will find all the threads come outside into the skin also. That is not an ideal situation. So you should use the correct length. The other one is a tapered pin. The fourth one that you see is a tapered pin. So it is conical in diameter. And what this does it, as it is advanced forward, a thicker part of the screws, the threaded part engage with the bone, so you get a better fixation. The next one that you see is the self-drilling, self-tapping. All you have to do is load this onto your drill. The pointed part does the drilling, and then it taps its own path and gets. This can be deployed extremely quickly. The last one is probably an example what you saw of the denim pin, where the central part is actually threaded, and this is used for transfixation shank screws. Coming to the material, typically they are made, pins are made of stainless steel or titanium. Titanium has the advantage of being biocompatible, reactions and all are less, but it is less stronger when compared to stainless steel. Coming to the end of the pin. So you can have an end which is blunt, or it could be sharp. A blunt pin can be straight, that is uniform diameter in the threaded portion, or an expanding diameter as you go proximally, it is conical. The sharp tip belongs to the self-drilling, self-tapping shank pin. Some advances have been done in order to prevent loosening, in order to prevent infection. These are the two common things that you see with a fixator. So the threaded portion has been coated with hydroxyapatite, trying to give a better fill and a better fit to the bone, because the stiffness of hydroxyapatite and the bone are similar. So you get a better fixation. Using chlorhexidine or silver impregnated coatings will help you to reduce the incidence of infection. So these are just studies which tell you that these things are actually quite useful. Again, it is not a procedure to be taken trivially, because the outcomes can be terrible. So when you put a pin, there must be a generous incision. You must go down to the bone, separating the soft tissue away right down to the bone. Use a very sharp drill, not a blunt drill which raises a lot of heat. Use a drill sleeve so that soft tissues don't get entrapped while you do drilling. Go through both the cortices, place the correct diameter pin there, avoid high speeds, avoid thermal necrosis. So only then is this pin that is anchored in bone is going to last long enough. Otherwise, you can have dramatic removal within 3 to 4 days if you've done if you have used a bad drill bit. If you have infection which has come through, it is a matter of minutes that the pin will come out. So these principles of pin insertion must be followed. So that is a self-drilling pin. The self-drilling pin must not go through the cortex because it is very sharp. So it must stop. It must just engage the opposite cortex. It need not come out like a conventional shank screw. Now this is just about a short drill flute. So the drill flute is the empty channel that has been cut into the threaded part. So you can see actually the photograph has moved a little bit, but the blue marking actually is for the fluted part. So the smaller the flute, the more thermal necrosis you get, because it will be fully filled up with bone. Whereas the last drill bit, if you see down, you can see flute. Flute is the narrow pathway, the hollow pathway that you see down. So when you drill, all the bone debris will go into the hollow part and it will not cause heat. Pins, half pins, they go through one side and they catch one cortex and they catch the opposite cortex. They do not come out through the other side. A shaft locked is a concept which I just told you. That means that the shaft of the shank pin must touch the bone. You cannot have threads sticking out. That is not an ideal fixator pin. Transfictions go right through and through. We must be careful about nerves and vessels while doing this. And these tractions actually allow easy transport. Again, from the World War, these used to be called in fact, the Hoffman fixator was a classical example of what was called a traveling fixator. Right through, quickly drill the shank pin right through, put fixators, transport the patient to a bigger hospital. This was the wartime medicine that was done. So just an example, what to use. 5 mm or 6 mm for the femur and tibia, humerus 5, forearm 4, and you could get smaller. Remember that you can go up to 1/3 the diameter of the bone. You can also, you should also be careful that if you drill too much, especially in a circular bone like the humerus, because the crack can probably, you make one hole here, you made a crack. In the same line, you make another hole. What happens? There is an invisible crack, and the second hole propagates the crack. And the more shank pin you pin, actually vertically split up the cylindrical bone. So you must be careful. Again, clamps, two types, multi-clamps and single clamps. The multi-clamp can take more than one pin. The clamps can be modular, which will allow you to adjust. The clamps can be pivots, which can allow you to allow for a little bit of maldirections of the shank pin to be adjusted. It must hold the pin very strongly to the frame. And the point to remember is the closer the clamp is to the bone, the more stronger the construct is. Connecting rods are the hollow rods that connect these different clamps. They may be made of steel, aluminum, or carbon fiber. Again, the bigger the diameter, the stronger it is. Sometimes you can add, instead of making a bigger diameter, you can add 2 rods, which also enhances the strength of the construct. So you can have different types of rods, a simple rod, an articulated, this is the modular frame where they're saying rod-to-rod connections, and a telescoping, which is the railroad fixator. Bars, again, we have spoken about them. Stainless steel and carbon and aluminum are the 3 common ones that are used. The carbon fiber has radiolucency. Same principle, bigger the diameter, the stronger it is. Carbon is actually more stronger. This is an important point to understand. Carbon is actually more stronger than stainless steel in failure. But the clamp to carbon rod fixation, that joint is weak. So it is almost similar. Okay, in fact, sometimes if you do a steel this thing, it is actually slightly stronger. The clamp is the weak link in a carbon fixator. Ring fixators, again, just to touch upon this. This actually needs probably another class. Tension thin wires and half pin clamps, rings and rods, and motors and hinges, all part of the Elizaro assembly, the ring fixator assembly. Just to touch on the principle, they are tensioned wires, and when they are tensioned to about 90 to 130 kilograms. It is good to place the wire perpendicular, like you see in this model, perpendicular, right angles to each other like that. So that gives you the most effective fit, and it captures the bone correctly. You can use half pins instead of volley wires. It is good to use full rings because they are stronger than 1/3 or Italian arches or smaller rings. They are very useful in the metaphyseal bone where they get a good purchase, where the shank screw can actually become loose. They also allow dynamic axial loading. If you just loosen the frame, then you get a little bit of micromotion and dynamization. And depending on how it is constructed, it can even allow movement of the joint. This is the hexapod system, which again we have talked about. It's very useful in deformity correction, and all the 6 degrees of freedom can be used. It has the benefit of having a computer software program which will tell you which to move first and which will to move how much. So that can do correction. Okay. What has happened?
Sir, it's there, sir.
Okay, I just meant. Okay. So this is the hexapod. What is that? Can you see it?
No,
yes,
suddenly
sir.
the screen is becoming white. Suddenly the screen is becoming white. Jagdish,
हाँ, I'll
Sir,
just see, sir.
this is a Beckett slide, I think.
नहीं sir, ये
अभी आ रहा है. Now it is there. Now it is there.
sir,
Okay.
there must be few blank slides, sir. That could be the reason. But we are seeing you,
Okay.
sir.
Okay, fine. So this is just, sorry for the trouble. This is just an example how an hexapod is used to get back alignment and union in a badly comminuted tibial fracture. So coming to the biomechanics, some physics. So the stiffness of a frame is a product of the elasticity of modulus and the inertia divided by the distance of the frame from the axis. This is an important point for you to understand because the stiffness of the frame is critical in stability. So the modulus of elasticity is of the material that is used, which is a constant. The moment of inertia is again a constant. So what is really in your hand for the frame is actually a distance from the axis. So the further you move the frame from the axis, the lesser will be the stability. The closer you come to the bone, more will be the stability. So these points are important for you to understand. The stiffness of an external fixator depends on the distance between the rod and the bone. Number of rods, you increase the rod, it becomes more stiff. Separation of the rods from each other. You keep the rods tightly close to each other, it will become a little more stiff. You put them apart, it will become less stiff. The number and diameter of the pins that are used and the relationship between the pins and the fracture and the pins themselves. We'll go in a little bit detail. So coming to the pin, so we have said that the stiffness is proportional to the radius of the diameter raised to 4. So the larger the pin, the greater the stiffness. Oops. So you can see this data which says that a 4 mm pin and a 5 mm pin, the 5 mm pin is actually 2.5 times more stiffer than a 4 mm pin. The 6 mm pin is actually 5 times more stiffer than a 4 mm pin. So you have to understand, the bigger the diameter, the better. The issue is do not cross 1. The blue arrow, you will see that in the first case, these pins are put wide apart. When you put them wide apart, you get better stability. In both these, in the two pictures on your right, you can see that the Shan's pins are very close to the bone, very close to each other, not to the bone, very close to each other. And there is a wide space of rod which is not connected by a Shan's pin. This is an unstable construct. So increasing the pin spread on the same side of the fracture, putting more number of pins will make the fixator more stable, more stronger. Sometimes oblique fractures are there. You can use oblique pins to counter the sliding and the shearing effects of the fracture line. So this is another way to do a construct. Again, the rod, if you see the first picture, the rod is very close to the axis, to the bone. That is a stable construct. The moment you move it away, you can see that the bone is wobbling. So if the rod is moved away from the bone, it becomes flex construct. Another way to make construct stronger is to put an additional rod. Therefore, it will become stronger. That is called stacking of the bars. That's the right thing to do, close to bone, but not so close that it hampers your addressing of the wound. It should be at a reasonable distance, close to the bone, but it should allow wound care also. So another way to make it construct is to make it into a more three-dimensional complex structure. A very popular in the foot and ankle injuries is the delta frame, where you create a triangular frame. And what this adds is it adds controls in more than one axis. Bipolar construct. Again, the ring fixator also, because it has a 360-degree hold, is extremely stable. We have spoken that the wire should be at best 90 degrees. When it is not possible, it should be as close as possible. Okay, otherwise it may be unstable. So this is just a fixator, just a question whether you can pick up whether something is wrong. So I can just tell you that there are 2 Shan's pins on top, 2 Shan's pins at the bottom, which are very closely applied. There's a huge gap between these 2 pins where only rods are there. The 2 pins are only in one plane, and this is a monoplanar fixator with a very less pin spread. This is going to be unstable. This is going to cause pain. This is going to cause infection. This is going to cause loss of failure, a loss of fixation. So again, a summary diagram. This, because this concept is important, it is important that you follow these principles. The diameter and the number of rods contribute to the stiffness. The diameter of the screw that you put into, or the shunt pin that you put into the bone, contributes to the stiffness. The distance between the pins and the fracture site. Again, the closer you are to the fracture site, the better hold you will get, and the better restriction of movement you will get. Distance between the pins if it also influences the stiffness. Distance between the clamp, rods, and bones also is the critical factor. Something which you can't control, obviously, is how osteoporotic or the holding strength of the bone. So all these factors influence the stiffness of a construct. We can always say that an additional rod will improve the stiffness even further. Okay. So how can you use a fixator? Compression. So the typical compression is the Charnley's arthrodesis camp, where you need fusion of the knee or fusion of the ankle. You compress the bone so that it fuses well. Typically, it is used in when you have good bone quality, sufficient bone stock, there's good contact. Typically, you want arthrodesis or good fracture union. Neutralization of is a concept where you have actually fixed the fracture by some other device. You have put a plate or you put something else, but it is not strong enough. So you augment the fixation. So what the fixator does here is it negates the deforming forces. It takes the shear away from the fracture. It further stabilizes. Distraction, as you know, is a very popular way of doing bone lengthening in distraction histoiogenesis. Just coming to the biology, what you can do, how you can alter the biology using an external fixator. The concept of dynamization, where if you make the fixator less stable by so many methods. Remember, you saw the methods. One of the ways could be to remove the additional rod. The other way could be to get the rod a little farther away. So if you reduce the stiffness, you get micro motion at the fracture site, and you get, this is from Perrin's original work where he showed that the micro motion actually produces callus. And not only that, it produces it shifts into a hard callus very quickly. Even the time that is taken for forming a callus is actually accelerated. So that's about the basic principles. Now, how to apply? There are 4 principles you have to keep in mind when you put an external fixator. One is the anatomy of the vital structures, the nerve, the muscle, the blood vessels, all you should know them. Remember, the fixator you're putting, especially in open fracture, the principle is you want to get access to the wound. You should not put a fixator that is extremely tight, well constructed, but does not allow you to dress the wound, does not allow you to put a flap and close the wound. The fixator must be mechanically stable, and it must be comfortable for the patient. So the anatomic considerations: know your anatomy before taking the shank spinning and driving it bone. Ask yourself, am I in the pathway of a vital structure? How can I avoid this? So follow that. Going down to bone, pushing away all the soft tissue is a good example of how to preserve. Using a sleeve is one way to protect the tendons and nerves. Do not put a fixator into the joint. If you get pin tract infection, it will end up in septic arthritis. Try to avoid if possible. Avoid the fracture hematoma also. If the skin is devitalized and degloved, don't put a pin through it, because you will finally have to take that out. Try not to go through big muscles and skewer them onto the bone. Okay. Pre-drill the cortex. Thermal necrosis is to be prevented so that you don't get a ring sequestrum, and use the correct length shank screw. Just principles. Okay. Safe zones, you must be knowing about this. You have atlases which tell you how to put in, which angle to put, how far to go to avoid vital structures. When you put it in diaphyseal bone, don't dangle the shank spin. It means that you have to catch the opposite cortex. And if it's a conventional sandwich, you have to catch the opposite cortex and go out of it. Only then you will get good fixation. Except in a self-drilling, because of its extremely sharp tip, just anchor it in the far cortex. Injury access, make sure you can access the wound. The bars and rods should not be very close. It's better to avoid pins that into the open wound. Okay, and then choose for patient comfort. You can actually choose for putting a small size fixator. Use the smaller pins in length so that it doesn't injure the other other leg and the patient is comfortable. So this is another important question. I have done an temporary external fixator. When can I do definitive fracture internal fixation? Typically, the answer is between 2 to 3 weeks. If you have signs of pin tract infection, do stage. Remove the pins, wait for some time, curate the site, and when there is good healing, go back directly. When there is established pin tract infection, please don't do internal fixation because that is an invitation for the implant to get infected. So what are the complications? We have talked about this before. Pin tract infections, mechanical failure, non-unions or malunions that are occurring due to fractures which are treated with the external fixators, soft tissue impalement, and compartment syndrome. So pin tract infection, I'm 14% is very less. It must be far more than that. And in fact, there is a classification where you have 4 stages. Stage 4 is frank osteomyelitis of the underneathing bone. And stage 1 is just a seropurulent discharge. So how do you prevent? Choose the subcutaneous border of the bone, the ulna, the shin of the fibula, where there is no soft tissue, there is no muscle, deep, big muscle, which you need to penetrate and go. Stay away from the zone of the injury. Make a generous incision. Don't bunch the skin around the Shan's pin. Use a cannula is actually a sleeve to prevent soft tissue injury. Use sharp drill bits. And when you put the Shan's pin, don't use power. Use the T handle. And then slowly, turn by turn, you fix the pin inside. So post-operative care of a pin is keep it clean. You can use saline. Some people recommend you can leave it over. Some people say you can use betadine gauzes or ointment gauzes. Both are equal. Patient is allowed to take a shower with the fixator on, especially if there is no other external wound. So how do you treat minor infection? Just clean it well. Do aggressive dressing. When you reach stage 2, where you have a little bit of loosening also, then it's the starting of loosening. You have to add oral antibiotics. If it is loose and there is deep infection, you have to remove the pin and put it somewhere else, plus add IV antibiotics. Stage 4 is almost like a bone osteomyelitis. You have to take a culture, antibiotics for longer time, and you have to do a judicious debridement of the pin tract. So these are the problems. Pin loosening can be differentiated from pin infection. You can get pin infection you can get pin loosening due to infection. You can also get it without infection. Thermal necrosis is a classical example. You drill with so high speed that you get a ring sequestrum and the bone around the pin is lost. Bending preload, some people, at least we were taught in our days, to pull the pins apart so that the fracture gets compressed. There's a pressure, there's a compression on the fracture by bending the pins away from the fracture site. This is called a bending preload. This is not recommended because it puts eccentric forces on the pin tract hole in the bone and will cause an eventual loosening. So use the correct pin. Radial preload, I'll explain later. Euthermic pin insertion means low speed drilling. Soft tissue release. If it's an open fracture and it is slow to heal, bone graft it early so that the fixator can be taken off early. Hydroxyapatite or antiseptic coating of the pins might help. So if the pin is loose, the last line is important. If the pin is loose, it has to go. You have to take it out. There's no point hanging a pin in a big cavity full of pus. So bending preload, like I showed on the left, is when you pull them apart, when they are applied angularly. A radial preload means that you drill slightly smaller than the Shan's pin. Typically, the Shan's pin that you use is a conical. So when you drill smaller, what happens is you get a really snug fit. Whereas if you drill equal with a little mobility and this thing, you might find that the pin tract becomes loose. So radial preload is making the drill hole smaller than the size of the Shan's. That is called radial. The word radial comes from radius of the hole. So radial preload. Frame failure, the frame breaking is unusual. It occurs when we recycle the frames, but we still do it. At least I do it in my hospital. So you can reuse the rings. What goes outside can be reused is our principle, isn't it? If you treat fractures, you might get malunion. The malunion occurs because one is during putting the fixator itself, the bone alignment is not correct. So the treatment is that you you prevent this. You keep the other limb for comparison so that you know the lie of the bone. Use X-rays intraoperatively to make sure that you're on the right plane, and use adequate construct. Sometimes the frame might fail and you might get a late failure, which might, if it is malunited, you have to do a osteotomy. Non-union, actually there is a study which says if you do internal fixation and you do external fixation, the rates are the same. How do you avoid non-union? By avoiding distraction. If the fracture requires a bone grafting, do it early. Make construct very strong. Follow the biology of surgery. Follow the principles of surgery. And if it is infected, treat it aggressively. Dynamization is one modulation which you can use with a fixator, which actually helps in avoiding non-union. Soft tissue impalement, you can get serious injury if you injure a nerve or vessel, or it can cause a loss of motion and scarring if you involve a muscle or a tendon. Check range of motion intraoperatively, avoid piercing muscles and tendons, keep the joint neutral, and then institute rigorous physiotherapy to prevent contractures. Compartment syndrome is rare, typically occurs when a big vein or a big vessel is punctured. Recognize it early and be careful. So this is the last slide. Use the optimal diameter pin, neither less nor more. Use a clean insertion technique. Follow the principal wells. Place the clamps and frames close to the skin so that you get good stability. The plane the frame should be plane in the force of the deforming forces. So if you have the tibia, when you flex the knee, the force is to cause a procavatum deformity at the fracture. So the best place for the frame is dead anterior there. So it will prevent this forces. You can stack the frame, use 2 bars if you want more stiffness. It's an extremely versatile tool and very useful in handling, especially some unsolvable problems can be solved by using an external fixator. So last slide, one of the mainstays of orthopedic, you must know it. It's a useful, like we said, it is a versatile way of treating different versions. You can get different functions, can be used as local damage control, can be used as damage control in polytrauma. The stability of a fixator is controlled by the surgeon who puts the fixator. Technique and location of the pin placement is difficult. Thank you.
Thank you very much, sir. Yeah, excellent as always, sir. Thank you very much. Clear, concept clearing, and yet simplified class, sir. Thank you very much from on behalf of all students, sir. And I have personally learned a lot. I would like to take now summarizing comments to start with, as usual, from teacher of teachers, Gopa Kumar, sir.
So, first of all, thank you, Jagdish, for the excellent presentation.
Thank you, sir. Good to see you. Long time.
Yeah, you have covered everything that the students should know, right from the history to the indications, then the classification of various types of fixators, and what are the types of shank spins. Then how to apply the shank spin, which are the safe zones. And one important question that is asked, how to increase the stability of the fixator. That is something which the students should know. And yeah, what are the problems associated with the fixation and other things. I think most of the things that are asked were covered. I think it was an excellent talk. And regarding Elisaro, I think basics of Elisaro and tech supports, because in one of the DNB exams in Calicut, our GJ was doing quite a lot of the tech supports, and these patients were in the ward, and the examiner was an Elisaro surgeon. So he was very keen to ask questions, and none of the students could answer anything. So you should know these also. Okay, I think Jain sir can.
Yeah, sir. If time permits, I'll give a basic outline of different ring fixators.
Yes, sir. 35 minutes are still there, sir. If it is with you ready, then you are welcome, sir. Today itself we should finish.
Sir, I have few guests waiting down.
Today no
Okay,
petrol.
sir.
Gopal.
No, I
Right,
also
sir.
have few guests waiting down, so I have to attend them
Right,
also.
sir. Sir, after this, whenever there is relevant case like that, we will think of this class, sir. Elizaro.
Yes. Yeah.
Yes, sir. Gopakumar, sir.
Yeah, I think that was an excellent presentation, and the students should have benefited quite a lot from this, because it is very commonly asked. I think the most commonly asked in the ward rounds. So they should know everything regarding this. Thank you.
Yeah, sir. Uday Kumar, sir.
Yes, sir. And then once again, thank you, Jagdish. We don't say congratulations. We have to say thank you for a wonderful talk. And very happy to see you back. And one comment really caught me, that really impressed me. The surgery is a consented assault on the patient. So everyone, before resorting indications for surgery, always think twice before, unless it is a absolute indication. We should not. Now the current trend is the people are trying to convert rare indication into absolute indications. Earlier days it was a relative indications to absolute indications. Now it is a jump to the one step down. So that is one point. Thank you for really bringing that point. And then another thing is, I had many of the times from the Menon Chaudhary, for all the proponents of LRS and opponents of Elizaro. They always, the opponents Elizaro says the Elizaro is the surgeon's delight, but patient's misery. That the standard dialogue everywhere. In fact, one of the conference there was a debate between Rajashekaran and Menon Chaudhary. Menon Chaudhary on one side, Rajashekaran is for LRS, Menon Chaudhary is for the Elizaro. In Guntur, maybe 10-15 years back, I still remember that was a beautiful debate. Yes. There, the Rajashekaran comment was, Elizaro is the patient's surgeon's delight and patient's misery. So that's one thing. We always enjoy, but the compliance is, hope Jayan Sharma won't customer, sir.
No, sir. Now the consensus is that for femur, we prefer a LRS, and
Yes.
for TBI, it is always ring fixator.
There another point, the one of the regarding the Elizaro, that one standard dialogue I used to hear. The wire under tension acts as a heavy screw. That is the basic principle of Elizaro. Wire under tension. So tensioning, that is one point, sir. And then another point, you already mentioned many times, but I would like to bring to the notice of the students again. You have to avoid the zone of injury while putting the pins. That is called the red zone of injury. So you have to know what is the extent of red zone of injury. That is very, very important. Suppose you are in the anxiety of putting the pins close to the fracture, sometimes you may pierce the zone of injury. That is the one reason for frequent infections, sir. And then last question, sir, how do you dynamize this monoaxial fixators with 2 rods? Just I would like to hear from you how you dynamize. You said progressive dynamization. Is it true with the Elizaro or with the conventional biplanar?
Conventional also there is dynamization, sir.
Conventional. How do you dynamize, sir?
Jagdish has mentioned about that, sir.
Actually, if there are 2 rods, you can remove one, or you can move the construct away from the bone.
Away from the bone.
Okay.
That is in a monolateral fixator. You can just move the clamp construct away from the bone, which will add a little more mobility to it.
Yeah, it will become less rigid.
If there are 2 rods, it will be easy.
Gopa, sir, you're not audible, so there's some.
Okay.
Yes, sir. Yes, sir. Gopa Kumar, sir.
Yeah, if there is a two rods in the same plane, the diagonally opposite clamps can be loosened, so that they will telescope a bit and give you mobility at the same time. This is what is given in the AO book.
That is the easiest way to do it. Easiest way.
Yes, that is the one that is advised.
Right, sir. Thank you, sir. Kakatkar, sir.
Good evening.
Good evening, Jagdish. Nice to see you after a long time,
Yes,
Yeah. Well, I think it was an excellent talk. And as Gopakumar sir said, you have covered practically all the aspects, right from historical aspect to the complications, and then the last message about the external fixator. I think I had to go out for a short time. I don't know whether you talked about shaft lock.
Yes, yes.
One thing which
I just mentioned.
you mentioned it. Okay.
I mentioned sir.
Because that's something, because for some time I had one emergency call, so I had to leave for a short time. But I think otherwise you have covered up everything, including the different designs and the self-drilling pins, especially in a polytrauma situation where you are using it as a damage control. I think that can really save time, because I am quite fond of using these self-drilling pins, and you can really save time. You to use a triple trocar, reach up to the bone and just put the pins on a drill. Only you have to control the speed of a drill, and that can really make your external fixation very fast. So that can be one of the things that the students must know, that the real indication for the self-drilling pins is in a damage control orthopedics.
Thank you, sir.
Otherwise, I think everything has been covered.
Sir, may I take few students' questions and then I will take comments from other faculties?
Sure. Definitely.
Jagdish sir.
Yes, sir.
Can we prefer manual drill or power drill?
Okay. Drill, the power is, the drill bit is actually suited for power, so that you need more RPM to push a drill. I do agree, if it's a very sharp bill and you move your hands really fast, you can manage it well with a hand drill also. But the shan spin has to be put by hand. It has to be put manually, slowly, turn by turn. It has to be put. You cannot rush it. You cannot rush it with power. You will get more heat.
Sir,
so it is better to use.
Yes, sir. If there is an associated vascular injury in polytrauma patient, do we still go with X-fix first, followed by vessel, or vice versa? Vascular repair, I mean.
There are many questions in that question. Okay, in a polytrauma, remember that the patient is critically ill, which means actually the orthopedic injury might be the lesser of the injury. He might be having a severe open chest trauma, or an abdominal injury, or a head injury which requires urgent thing. There, in that case, now if the patient's life is at danger, life takes precedence over limb, and you would actually deal with the chest trauma which is bleeding, or the abdominal spleen which is bleeding, you would go and do that. Now, that answers the question which to do first. Now, if you have a vessel injury, it is good to stabilize first before repairing. So if you repair and then if you move the patient and gets him, your repair gets compromised and it fails. So it is always good, something with the, like sir was suggesting, a quick external fixate, which takes you about 10 minutes, and you stabilize the bone, move aside, give the feel for the vascular surgeon, let him come in, open the vessel and do an anastomosis. So fix.
Sir, yes, sir.
I have one question, Gopal, 1 minute. I have question to Anuj Roy.
Yes, sir.
These are
more of theoretical questions he has placed.
I want to ask him, does he know the definition of polytrauma and multiple trauma?
Yes, sir. Anuj, unmute.
Yes, sir. Good evening.
Because the question he has asked shows that he does not know what is polytrauma.
Yes, sir. Anuj.
Yes, sir.
Definition of polytrauma.
Sir, polytrauma means that there is more than there is a visceral or visceral injury as well as a musculoskeletal injury.
More than one system.
More than one system, and one of the injuries is life-threatening.
Yeah.
That is it.
Then if I am having both femur fractures, is it polytrauma, Anuj? It is one system only.
Cannot comment.
Cannot comment. Okay,
yes,
go back, read and put on students group. Okay.
Yes, sir.
You better go and read Watson Jones' first volume for this.
Right, sir.
The best place to read about this.
Okay.
Right, sir.
Then multi-trauma now. Second.
Pardon?
Sir,
Can you get
Sir,
a Watson Jones nowadays?
Yes, sir. Watson.
It is available, sir. It is available.
Sir, now old wine in new attractive cover page is there with some reduction of pages. Sir, I think 6-7 years back, new edition has come, sir.
That was edited by Matthew Varghese.
Yes, sir.
I have the PDF, sir. If you want, I can share that PDF.
I have
Wow.
the original.
The old one PDF.
Old and new both.
The newer one, single volume, I have purchased around 6-7 years back, sir. Sir,
I have got the original.
right,
I have the 2 volumes. Last one, I have one copy.
Sir, Anuj has asked 2 more questions. I think I will complete. Can internal fixation and external fixation coexist together?
Yes, very much, very much. You can do that. That in fact forms one of the pillars of hybrid fixation. A classical example would be a tibial plafond fracture where you have opened it and minimally fixed it with cancellous screws, a couple of cancellous screws. But you decide that you need to neutralize the forces, so you can put an external fixator. It can be done. It can be done.
No, one more indication is where they do lengthening with fixator. So to minimize the period of fixator, you have a intramedullary rod and you do the lengthening, and then instead of keeping the fixator on for a long time, what you do is you lock the nail and you remove the fixator so that the gap gets filled up with bone and the inconvenience of a fixator for a long time is avoided. So that's a lengthening over the nail with the help of a fixator. That is one.
This was our master class of Asami last week.
Yeah.
And especially for femur and tibia, not for the upper limb. Sir, last question. You have already answered, but if there is proximal tibia fracture, how close I can be close to the joint? Jagdish,
okay, if it's an articular fracture, that means you have to be really close to it. Remember that the knee joint capsule is said to be about 12 to 14 millimeters distal to the tibial joint line. So any pin that you put there is actually going to go through the knee joint capsule. It's going to be in the new gene cavity. But if the fracture pattern so dictates and you need a very proximal hold, you must do it. You must do it. Only thing, you would be very meticulous and you would prevent pin tract infection. So
sir, one question is just with reference to your that actors external fixator to clavicle. I think this was not the message of this class that you should use the external fixator for clavicle. Dr. K. Sanjeev Kumar.
No.
Extrapolated and rare thing. In exam, don't utter rare words about rare things. You will be rarely correct and you will rarely pass. So again, I am putting this question to you, sir. What type of fracture pattern is ideal for external fixator in clavicle? I have already answered the question, but I want to know from you, Kakatkar sir and Gopakumar sir. For clavicle, what type of fracture pattern is ideal for external fixation?
Well, if at all you want to put in a fixator, then it's only for a comminuted fracture where you feel that you have to do a open reduction and stabilization. In case you want to avoid that, then maybe you can put external fixator and get the alignment and keep it stabilized by the external.
Am I audible, sir? Or my net is unstable? Jagdish sir.
Okay.
I have used it in, I have used a clavicle locking plate as an external fixator.
Okay.
In a compound fracture of clavicle, oblique fracture.
Okay.
Jagdish sir, your comments and then Gopakumar
My
sir.
comment is don't use an external fixator for a clavicle. That is my comment.
Sir, Gopakumar sir.
Don't use it.
I have never used it, If you are using some people, because they are low profile and you need only KYS. But in that area, maybe a bit dangerous.
Yeah, I think.
They are, I think, very vital structures near the clavicle.
Yeah, subclavian.
Very
More, we will do more harm than good actually. So rare things not to be told. This was just an example that when someone insists for some particular or rare thing, and the person who put this must be also a boss of boss, means a master of master like Gopakumar sir. So it is not our cup of tea, and definitely not to speak, open our trap in exam to get it trapped.
Jagdish also.
So definitely, sir. So
Samanta sir is quiet since long.
No,
comment, sir.
I'm just listening. Everything. I think we are discussing absolutely the basic thing. I think the external fixator for the clavicle is never going to be asked and discussed anyway in the theory or in the practical. So basically, the out of the way of discussion.
All right, sir. This must be, sir, I think super gold medal question. If at all somebody reaches there, else 100% going to fail on this. Now I will request Samantha, sir.
I think one of the things that can be told in, if you want to really have minimal scar, one can think of putting an intramedullary nail in the clavicle, elastic titanium nail. But that too also if it's a middle 1/3 fracture. If it's an outer 1/3, then you can't really use it because the bone becomes flat and the marrow is almost non-existent. So that can be given if somebody wants an answer of some minimally invasive technique and no scar or minimal scar.
Sir, some anatomist type orthopedic surgeon, he says, tell me the peculiarities of clavicle. Important peculiarities.
It's a common question. Gopal, this is a very common question.
Yes, sir.
And
Yes,
if
sir.
the student is failing in all his cases, he's definitely asked this question table.
And the same students will definitely tell about what Kakatkar told about intramedullary fixation. And the person will, like the anatomist type person will definitely ask, so what are the basic peculiarities of clavicle? It has no medullary cavity as per anatomy teaching. Then, sir, my question again, should we attempt or tell in an exam for clavicle fixation intramedullary screw? Jayant, sir, question to you.
No, I have not
Yes,
heard
sir.
of intramedullary screw.
What sir has?
Intramedullary screw, I think it is just theoretical. Nobody in the main trauma surgeons, they are not putting the intramedullary screw inside the clavicle. But the two probably makes sort of thing fixation is the either intramedullary malleable rod, or else you can put your clavicle specific anatomical clavicle plates.
Yes.
Sir Kakatkar, sir, you just told about the minimally invasive single screw, but
not screw.
No,
I mentioned about intramedullary elastic titanium nail.
Yes,
That's also in the fractures which are in the middle 1/3 or on medial side of the clavicle, medial 1/3, wherein you can go from the medial side, you can take an entry and you can negotiate the nail under the C-arm control and just pass the fracture site and cut the nail short. That is something which some people are doing, and that can be one of the options if the fracture is in this area.
True, sir. But should student tell this in exam? Because chances of injuring the vessels and underlying structures, because even if you will cut at least 1 centimeter away from the clavicle.
No, but
this has to be said. This is
entry point is on the anteromedial side. So if you are careful enough not to perforate the clavicle, then the injury to the vessel is not possible.
I think students must go home today from this class about the clavicle fixation is that till the middle third or comminuted fracture, as Kakatkar sir is telling, you can go with the flexible nailing system, or else you can go with the plate.
Yes.
If it is a fracture of the lateral third, you have to go with the anatomical plate, which is specifically designed for the lateral third clavicle. I think this is the end of the fixation of clavicle. Forget about, there is no screws, no trauma surgeon. I think I know those are big numbers they are doing. They are never applying the screws for the clavicle.
No.
Right, sir. Samantha, sir, your comments.
No, there is no question of comment because Jagdish is a master of any subject. Whenever he is doing, I am just looking, I am just listening to like a student. So he has already covered everything. Whatever he has told, if something remains in your brain, I think the students will be answering every question in the theory and both in the practical. And every alternate student in the ward round for the DNB will definitely get a externally fixed patient in the ward round. So if you just fail any question in the external fixator, it is very hard to pass in the DNB practical if it a physical exam.
This is going to be physical, they have said.
But one thing regarding clavicle, I have been doing comminuted fracture, open it, pass the A wire laterally, and then get it through the skin, reduce it, pass it medially, and cut it and bend the wire. It is not protruding, it's comfortable, and it's anatomical reduction in comminuted fracture without disturbing soft tissue.
Sir, my question to now.
I have seen from somewhere, and it is doing very good.
Right, sir. But in literature, there are reports of migration of K wire in the heart.
No, he said he'll bend it.
This is bended.
Yes, sir. But
and it is not pinching also over the scapula. I think I can.
Sir, my question. Yes, sir. Very true, sir. I understood. But my question to senior examiners: would they like about K wire answer or this sort of option? Should they utter such this type of fixations in the exam? As an examiner, Gopakumar sir, Samantha sir, Jayant sir, would you like this answer? Because few examiners may not like K wire.
See, if the student can say he has seen like this, he has seen like this, he can say, I have seen like this. May not
Right, sir. I understood your sir. A senior person and master like you, it's okay. But for exam purpose, Jagdish sir, all those are examiners. All examiners, sir. I'll request. Yes, sir.
Gopal, just I will take just 1 minute for that. If your something is asked for the clavicle fracture management, in the practical, tell that I will manage mostly. I will manage all the young or the whatever clavicle fracture. Yes. So you have to understand the absolute indication and the relative indication of doing surgery for the clavicle. And if at all you are doing surgery, there are two modes of fixation. One is the flexible intramedullary rod, or else it is a plate for the up to the middle third of the clavicle. While the fracture is in the lateral third, then you have to fix with the anatomical plate. I think you have to stop here. No senior or the junior examiners are going to poke you rather beyond this answer. I think Kakatkar sir and Gopakumar sir and Joyan sir all will agree on that.
Absolutely. Absolutely.
Right, sir. Sivananda sir. Yes, sir.
Sir, as usual, talk is excellent. And my question to Jagdish sir, what are the principles, what are the precautions we must take while using external fixator as in the principle of ligamentotaxis?
Okay, what are the principles that you would take in ligamentotaxis?
Yes.
Okay. I think the principles would remain the same. The principles would be still to get a adequate purchase on both sides of where you're doing ligamentous taxis. The good purchase actually again depends on correct pin placement, correct diameter of the pin, correct depth of the pin, and then applying a suitable construct. In when we do ligamentotaxis as a prelude, as a temporary procedure before definitive internal fixation, it is best to put the pins in a corridor where the skin incision will not come. So if you have a tibial condyle or a distal femoral where you're going to expose through a lateral incision, it would be probably better to put the fixator in the mid anterior plane, trying to avoid going through the bulky part of the quadriceps, but it should be kept away from the definitive incision for the surgery. That's about I can think of. You can help me if I miss something, sir.
No, I think Jagdish, you have covered everything. Another thing is that suppose most of the time either we are doing for the tibia or else we are probably most of the time doing for the comminuted distal radius fracture.
Distal radius, yes, sir.
So if you, the question is that how you put this thing, so it should be kept in such a manner, or you have to you have to fix this in such a plane that it doesn't go into the palmar or the dorsiflexum sort of scenario, so that your intention of putting the pain in such a way or distraction rod in such a way that it moves in the axis of the wrist. It doesn't deviate in the dorsi or the palmar way. So that is
where the modular fixator will help.
That's why your modular fixator, because if you go in uniplanar sort of fixation with a single sort of nut at the end of it, then it's a problem. But if you have keep it in a modular frame, then you can manage that it goes in the axis of the joint. So this is the way you have to think it of. I think that will cover the question what Dr. Sivan is asked for. So this can be used for, Jagdish has pointed in the right way. It can be used in two ways. One is the temporary way as for the reduction degree in the definitive surgery, or it can be used for a comminuted intra-articular fractures where you will keep it as the ligamenotaxis just to reduce the fragment by the tension of the ligaments.
Can I add?
Yes, sir. Yes, sir.
Yeah, especially because this ligamenotaxis, the commonest place where we use it is actually distal end radius fractures. And there are 2-3 important precautions one has to take. When you are doing distraction, many a times to get the alignment of the fragments, you have to over distract. But in that situation, once you have reduced the fragments in alignment, try and pass 1 or 2 K wires to get the stability and immediately avoid the over distraction. You can come back and bring the tension to fairly normal tension. If you are seeing that the joint space is widely opened out, it means you are inviting a problem of RSG in these patients. Because any over distraction in a distal end radius, the commonest complication you will end up with is a reflex sympathetic dystrophy. And then it really becomes difficult to get rid of that particular problem. So you can over distract on the table, achieve temporary stabilization with K-wire, and immediately reduce the over distraction. I think that is one of the important technical points for the distal end radius that you have to remember. Shivanand, I think.
Yes, sir. Yes, sir.
Yeah.
That is the most important thing is to prevent, to avoid stiffness, because all the junior surgeons, they try to over distract it.
Yeah,
absolutely.
That is a common thing. So the best technique is once we applied the fixator, then ask the patient to, you see the tension of the fingers, whether they can able to get the complete flexion or not on all the joints. If all the joints are flexing very easily, then that means the tension is perfect. Otherwise, ultimately it land up with stiffness of the fingers.
So we are
Jagdish,
doing
sir, any experience of a pinless external fixator, sir?
No, sir. No, sir. I haven't used.
Right.
Sivananda sir, we are doing a comparative study of Elizurov for distal radius with JS fixators.
Okay.
So we'll come up very soon with the results.
Sir.
Which one is better?
Okay.
Ligamenotaxis.
There is an articulated fixator which has a ball and socket joint, which is particularly useful in the distal radius.
Yeah.
I don't know what is the name, but there is a one which has a ball and socket joint, and you can just keep manipulating to whichever way you want.
No, in that particular fixator, I have used that kind of a design. It was initially introduced by one Mr. Karkhanis from Mumbai, who was a close associated with Dr. Vikas Agashe. and I have used that fixator. It has got a hinge-like mechanism. So after you get some stability, you can loosen that hinge and you can allow the dorsiflexion, palmar flexion movement with the fixator on, so as to prevent the stiffness. But it hasn't really stood the test of time. It was introduced, but I think hardly anybody is using now.
Actually, I have tried it, but then I stopped it because the stability.
Another indication for osteotomies.
Yeah.
So high tibial osteotomy, they're same that ball and socket hinge, we will use it and we can do that high tibial osteotomy.
Yeah.
Sir, two more questions are there from students. First question is, we have open type 2 open wound, which is away from fracture site. Should we open fracture site and attempt anatomical open fracture external fixator management as a definitive management? I think answer is no. External fixator, if wound is away from fracture site, even if it is type 2 wound, we should not unnecessarily open the fracture if wound is away from the fracture. Sir, Jagdish sir, your comment, sir.
Okay, type 2 is a little bit of a gray area, a type 2 open fracture. If the wound is very small without contamination and the patient comes early to you, within what we call the golden hour, 6 to 8 hours, you get the patient, and you are very confident of doing a good debridement, you can actually go down and do the definitive surgery itself.
Yeah.
So you can do an intramedullary nail under the cover of IV antibiotics and treat it like a closed fracture and do good wound management. Again, the 2 centimeters with contamination, delayed wound, here you would be a little more cautious and you would do an external fixator, align the bone and do soft tissue management.
Sir, but wound is away from the fracture site, sir. Wound is not at fracture site.
Gopal, the question he was asking for, Jagdish, just excuse 1 second. He was asking that whether he, for the sake of reduction of the fracture, whether he has to extend the wound, yes or no. I think that will completely be dictated by the time since injury and how much it is away from the wound. Your fracture reduction in external fixator, never it is needed that you have to see the fracture end naked eye. So if your wound doesn't dictate you to tell it to be opened, that is just for the sake of fracture reduction, you don't open the fracture, because you will devascularize the fracture, you will contaminate more. The main idea of the wound management is your creating thorough debridement. Thorough debridement is equal to a surgical wound. So this is the basic dictum you have to remember.
Right, sir. Thank you, sir. Sir, can we use a long DCP as an external fixator?
Not as a DCP, but a locked LC DCP, a locked DCP, not an LC DCP. A locked plate can be used. It can be used as somebody called it an external internal fixator. There are few studies. A lot of them are from India. In fact, the first experimental study came actually from the AO school itself, where they had showed it to be used, actually the tibia. I remember it was published in Injury. And we had this golden looking plate with orange and blue screws, locked screws, which was outside looking very attractive. Can be done. One of the great advantages of the external fixator is its cost. I think when you start comparing it to a locked plate, they are not comparable. You might as well use an external fixator, rather pays 40 or 50,000 worth of metalware outside the body. I think there are cheaper ways and better ways to do it.
Yeah. Right, it is just theoretical to use a lock plate as the external fixator. Mostly it is used for the proximal tibia and distal tibia sort of thing. But if you compare the cost of it and the feasibility of doing it, I think it is more harmful rather than having the advantage of doing this sort of lock plate with beautiful looking green screws, rather than having a simple X-fix which can be applied in 10 minutes time.
Yeah.
Thank you, sir. Now, before concluding remarks from Kakatkar sir to conclude today's session, Kanojiya sir, sir.
Gopal sir, one comment.
Sir, after Kanojiya sir's turn, sir. Kanojiya sir.
well explained everything, and he has explained the one should know the principles when he is applying, and also for what, as he has said, whether it is for soft tissue tear or
Your voice, Kanu, is not coming.
voice is not.
Or you can hold it closer to your mouth.
Yeah, you can hold it closer.
Hello, अभी आ रही क्या?
अभी थोड़ी आ रही है.
Now it is clear. Now it is clear.
I think I was relaxing too much.
Mic should be closer, sir.
आवाज नहीं आ रहा है सर, माइक क्लोज पकड़िए.
No, he is using earphones.
I am using earphone.
Oh, but then the mic of the earphone should be close to your mouth.
I might have gone into low volume. Low volume.
नहीं, अभी नहीं आ रही.
अभी आ रही है सर.
थोड़ी आ रही है.
He has explained the principles while using one should know also for what, like crisis management in emergency or wound management. So, and everything is covered.
Right. Thank you, sir. Sir, your comment, sir.
Yes.
Uday Kumar, sir.
Sir, only one comment is regarding the intramedullary fixation of the clavicle fractures. In fact, if 2-3 years back, I was treating a young unmarried girl, came with a little bit widely displaced clavicle fracture. Usually I never operate, but here I don't want to give her any scar, but looking at the fracture side, the family is not convinced that I want to treat that conservatively. So what I did a entry from the sternal end of the clavicle and put a tense nail. A very thin tense nail. But what happened there, after removal of the tense nail, the girl developed a very ugly keloid there. At one point, I want to bring to your kind attention that there are chances of sometimes you can have a ugly keloid. There was no scar at the fracture site, but she developed ugly keloid, 2 places, because I put 2 entry points. Both places, there is an ugly scar. That is the one point I want to.
Cosmetic, uncosmetic.
Keloid is a tendency of the skin.
Keloid is a tendency. That is not your fault. It is a tendency. It is
not the fault of a technique or of any surgeon or anybody. You know, people who take small vaccine also, they develop keloid.
Yes.
So I think it's the tendency of the skin rather than, yeah.
And I think Uday Kumar sir is lucky in the way he has not given given the choice for the plate. Otherwise, would have been a big keloid.
Sir, I am afraid of the plate, sir. I never do plating, sir. I never do. I am very happy with my conservative treatment.
Retrograde K-wiring, if I get cases.
But I had a better experience. K-wire migrated into the subclavian vessel once. Where there was no CR, we had to take X-rays and mark it and then remove it. That's one of my experience. Early days of my assistant career, sir.
So,
cases and good reduction and take out after 6 to 8 weeks.
Right, sir. Thank you very much, sir. Concluding remarks from Kakatkar, sir, for concluding today's session. Sir.
I think Jagdish has done a fantastic job of covering a very important theoretical and practical topic for the exam. Plus, I think it's a very useful topic for every orthopedic surgeon in his own practice also. I think a lot of small practical points were discussed in the post-lecture discussion also. And a very comprehensive message about the external fixator uses, indications, complications, and how to manage them, I think has been given in the today's talk. I think we are thankful to Jagdish for a beautiful talk and beautiful discussion by all the faculty members to bring out all the small points on which people can face problems in the exam as well as in their day-to-day practice.
Thank you, sir. With this,
Shivanand sir wanted to say something.
Yes, sir. No, sir. It's a wonderful talk. We
right,
enjoyed.
Sir.
We enjoyed.
Right, sir.
Jagdish sir talk, we enjoyed.
Right, sir. Now 5 minutes already passed. ये कारला सर नहीं है आज पेट्रोल खत्म का टाइम 5 मिनट पहले